In our previous discussion, we said that pregnancy is the state of having products of conception implanted normally or abnormally in the uterus or elsewhere. And we also said that the pregnancy may be terminated spontaneously or through an elective abortion or by delivery. If this is the first time you are watching this video, I would advise that you go back to our introductory video for more explanation to pregnancy and its terminologies. Now, in diagnosing pregnancy, we must know that in sexually active women who have regular menstrual cycles, instances of delay by more than a few days to a week may be suggestive of pregnancy to them. Now, some women diagnose pregnancy themselves even before she misses her period. And this is because they usually feel different. And so there are some signs and symptoms which can help us rule in pregnancy. And these symptoms may even confirm the woman's suspicion of pregnancy even before she comes to see the doctor. And so we have grouped these signs and symptoms under the presumptive signs, the probable signs, as well as the positive signs of pregnancy. So when we pick the presumptive signs of pregnancy, we are going to look at them in terms of the sign itself, the age of gestation at which we may elicit such a sign, and we are also going to look at how to differentiate it from certain conditions, because it is presumptive sign or it is a possible sign, which means that not all the signs when found in a woman may be suggestive of pregnancy, and so we should be able to differentiate it from other conditions. So the first sign we are going to look at is amenorrhea. This is the absence of menses for any period of time, and it is the most common sign of pregnancy, which may be seen by the 4th week of pregnancy. Now, we only presume pregnancy because even though in pregnant states there is loss of menses, it could also be due to emotional disturbances. Sometimes change in environment can also cause amenorrhea, or even some serious illness may cause amenorrhea. And so this is why amenorrhea is not a reliable pregnancy indicator until about 10 days or more after the expected menses is missed. Now, importantly, is occasionally we may have uterine bleeding occurring after conception. This is what we call implantational bleed, and may somewhat be suggestive of menstruation. And so during the first month of pregnancy, such episodes are likely to be the consequences of blastocyst implantation. And so we still advocate that during the first trimester of pregnancy, any bleeding should generally prompt the doctor's attention to an abnormal pregnancy until we rule it out. The second sign we are going to look at, or the symptom we are going to look at, is morning sickness. Now, this is also known as, nausea and vomiting occurring from the 4th to the 14th week of gestation. And it can be differentiated from gestational disorders such as the, hydatidiform moles, and also pyrexia illnesses and even cerebral irritation can cause morning sickness. And so we can only presume that it is pregnancy until further or more accurate investigations are done. The next sign and symptom that we can talk about is breast changes. And these usually occur between the 3rd and the 4th week of pregnancy. And the use of certain contraceptive pills may also cause certain changes in the breast. And so the presence of such breast changes may not only suggest pregnancy until we do further, investigations. And so the woman may complain of tingling and prickling sensation in the breast. And there may also be what we call the Montgomery's tubercle. The woman may see certain changes around, the secondary areola, or some bumps around the secondary areola. I'll show you very soon. And these Montgomery's tubercles are actually sebaceous glands, which are usually around 12 to 30 in each, breast. I'll show you a picture soon. Then the woman may also, we may also find darkening of the primary areola at the 12th week of gestation. And also the nipples may become larger and more erect in pregnancy. Now, by the 16th week of gestation, the secondary areola may appear and colostrum can be expressed. Now, remember that colostrum is the thick yellowish secretion which is rich in immunoglobulins, which protect against pathogens and also boosts the physiological performance of the child and also help in growth and development of the child. I'll show you certain images of the breast changes very soon. But before that, we may also have what we call bladder irritation between the 6th and the 12th week of gestation. And it is usually due to the fact that the bladder and the uterus share a common space. And so as the pregnancy advances, the uterus tends to put pressure on the bladder, and so it irritates the bladder, and this is somehow also usually felt by the women. So they usually have frequent urination. This bladder irritability can also be differentiated from urinary tract infections and even pelvic tumors. So the fact that the woman has bladder irritation alone is not suggestive of pregnancy. We need to differentiate it from other conditions. Then also we may have what we call quickening, and this is the first time the woman feels the movement of the fetus. It usually occurs by the 16th to the 20th week of gestation, and we can differentiate it from intestinal movement. The quickening may occur quite earlier in the multiparous women. Now, these are the presumptive signs of pregnancy. And so when we look at this image, we are going to see the breast changes that we just talked about, with the first one talking about the papilla. As you can see, it is more erect, and as you can see, the nipples have become a bit larger. Then we have the secondary areola, which is formed. Then also we have the Montgomery's tubercle. Now, with our probable signs of pregnancy, it is important for us to know that all biochemical pregnancy test depends on the detection of human chorionic gonadotropin, hormone, which is usually produced by the trophoblast. When we find the ACG in the blood by the 6th to the 9th days of gestation, or in the urine by the 14th day of gestation, we may probably think of pregnancy. However, the presence of hydatidiform mole and even choriocarcinoma may also, cause the production of human chorionic gonadotropin hormone in the blood as well as in the urine. Now, the production of the human chorionic gonadotropin hormone starts on the day of implantation and can be detected in the blood in these days as I've already stated. The hydatidiform mole may cause the production of HCG, because we said that the syncytial trophoblast, in the syncytial trophoblast, we have excessive proliferation of it. And this is the structure which also produces the human chorionic gonadotropin hormone. And so in hydatidiform mole, where we have such proliferation, we are going to have excess production of human chorionic gonadotropin hormone. And so when we find this in the blood or in the urine, we may, only say it's a probable sign of pregnancy until further investigations are done to confirm it. Now, any HCG level which is less than 5 milli-international units per mil is considered to be negative for pregnancy, and any HCG level which is more than 25 milli-international units per mil is considered positive for pregnancy. Now, the urine beta HCG is a qualitative test because it is looking at the presence of HCG. It's quite less sensitive as compared to the beta serum HCG, which actually quantifies the number of human chorionic gonadotropic hormone in the blood. And so it is much sensitive as compared to the urine beta HCG. Because of this low sensitivity of the urine beta HCG, we advocate that the results of it should be confirmed with either the serum beta HCG or an ultrasound. Now, normally, the beta HCG concentration doubles every 48 to 72 hours within the first 4 weeks of gestation until it reaches about 10,000 to 20,000, and it peaks around the 8th to the 10th week of gestation. And when we talk about the discriminatory zone, we are referring to the number or the amount of beta HCG which is present in the blood at a point in time. And so the discriminatory zone for beta HCG is 1,500 to 1,800 milli-international units per mil, and up to, this is usually in the pre-gravid woman, and up to 2,300 milli-international units in the multiple pregnancy. And so the idea is any beta HCG level above 1,800, we should be able to see the gestational sac within the uterus in a normal pregnancy when we do the transvaginal ultrasound. And so the absence of an intrauterine pregnancy on ultrasound when the human chorionic gonadotropin hormone is above the discriminatory zone may represent a recent abortion or an ectopic gestation until proven otherwise. Sometimes, however, the HCG levels may be either too high or maybe too low, and we should know what is causing a high or low levels of human chorionic gonadotropic hormone. And so the most common cause of high HCG is wrong dating. This is because if, for instance, the woman's LMP is 5 weeks, the woman should have an HCG level between 18 and 7,340 milli-international units per mil. And so if mistakenly we quote 7 to 8 weeks instead of 5 weeks LMP, we are going to get very high levels of the HCG, around 7,650 to 229,000. In multiple pregnancy, we are having 2 placentae producing the HCG, and so it will be very high as compared to a singleton. Other causes may be, gestational trophoblastic disease, such as the complete and incomplete mole, as in molar pregnancies, and also in choriocarcinoma, as well as in some chromosomal abnormalities such as the Down syndrome. Also, the number one cause of low HCG is wrong dating, and the reason is almost the same as I have given. Now, anytime you have a low HCG, the doctor's attention should be drawn to a miscarriage, because the pregnancy is no more and the HCG is no longer being produced, and so miscarriage is another cause of a low HCG. We should also think of a blighted ovum, and most importantly, we must think of an ectopic gestation. Then we also can think of other congenital abnormalities such as the Pateau and the Edwards syndrome. Now we should know that the HCG levels should return to non-pregnancy state or non-pregnant range between the 4th and the 6th week after the pregnancy has been terminated. Now, the other probable signs of pregnancy that we can look at include the Hager's sign. And the Hager's sign is elicited between the 6th and the 12th weeks of gestation, and we can differentiate it with pelvic congestion. Now, Hager's sign is the softening of the cervical isthmus. And this is actually quite difficult to elicit, and this is why most inexperienced examiners may mistake it for pelvic congestion. The Chadwick sign, which is the bluish discoloration of the vagina and the cervix, and this is usually due to increased vascularity in the area. Now, it is elicited between the 8th week of gestation, and it can also be differentiated with pelvic congestion. Then we also have what we call the Osiander's sign, which is the increased pulsation of blood in the uterine arteries, and it can be felt by palpating the lateral fornixes of the vagina. It may also be elicited by the 8th week of gestation, and it's also differentiated with pelvic congestion. Uterine growth and enlargement is usually seen by the 8th week of gestation, and we should remember that other masses such as fibroids also cause uterine enlargement. Abnormal uterine enlargement may be due to even tumors, as well as even ascites can cause an enlargement in the abdomen, and so seeing an enlarged uterus alone may not be conclusive of pregnancy, and so it's only a probable sign of pregnancy until we rule out tumors, fibroid, and ascites. Now, these skin changes occur in several ways, including what we call the linea nigra as well as the chloasma. Then we have what we call the uterine souffle. When we say uterine souffle, it's usually seen between the 12th and the 6th week of pregnancy, and it's usually due to increased flow of blood. Sometimes you may also see it in myomas as well as ovarian tumors, and this is elicited using a stethoscope for auscultating soft blowing sound that is usually synchronous with the maternal pulse. And so as you check the maternal pulse, you auscultate the lower portions of the uterus, and you may hear this soft blowing sound, which we call the uterine souffle. In contrast to this, we have what we call the phonic souffle, and this is rather a sharp whistling sound that is synchronous with the fetal pulse. And so, whilst the uterine souffle is synchronous with the maternal pulse, the phonic souffle is synchronous with the fetal pulse, and this is how you can differentiate the two. Now, Braxton Hicks contraction, which is usually by the 16th week of gestation, and this Braxton Hicks contraction by 16th to 20th week of gestation, the woman may complain of some contractions, and so we call it the false contraction, and it's also a probable sign of pregnancy. Then also we have ballotment of the uterus by the 16th and the 28th week of gestation. Now, telangiectasis and palmar erythema may be differentiated with the use of oral contraceptive pills, and also some conditions such as liver cirrhosis. These lists are not exhaustive when it comes to the probable signs of pregnancy. We have other signs such as even the Goodell sign, which is the softening and the cyanosis of the cervix around the 4th week of pregnancy. We may also even have what we call the Ladin's sign, which is the softening of the midline of the uterus by the 6th week of gestation. So the list I have here isn't exhaustive of the probable signs of pregnancy. So these are the skin changes we may find in pregnancy, and the first one is what we call the linea nigra. As you can see, it extends from the symphysis pubis to the upper part of the abdomen, and now this is a black line, and so it's also known as the pregnancy line, and it is a physiological form of hyperpigmentation which is commonly seen in the first trimester of pregnancy. Estrogen activates intracellular estrogen receptors which are located in the skin, thereby stimulating melanocytes to increase in melanin production. Also in pregnancy, the placenta makes increasing amount of melanocyte stimulating hormone, and this comes together to cause the hyperpigmentation which we find as linea nigra. The other one we can talk about is what we call cloasma, and this shares the same physiology as linea nigra. The only difference between the two is that the hyperpigmentation in cloasma occurs on the face, and so we may see it on the cheeks, the forehead, and even on the nose, and it's usually by the 16th week of gestation. Then we also have what we call the striae gravidarum, and this is also known as the stretch mark of pregnancy, and it's usually purplish red lesion, and sometimes becomes white and smooth, shiny and depressed. It occurs in response to changes in gaining of weight, or the muscle mass, or even tension in the skin. And so as the skin stretches in pregnancy, it disrupts the collagen fibers and the elastin in the dermis as the uterine or as the uterus grows. And this is how come we get these stretch marks of pregnancy. It sometimes causes itching and discomfort, and it's usually seen in about 50 to 90% of pregnant women, and so it's very common. We may not find it only on the abdomen, but it may also be seen sometimes around the breast and even the inner thigh. Now we can also talk about telangiectasis, which is the dilatation of small intradermal blood vessels, as you can see, and it looks red to dark blue in color, and they usually develop in the lower extremities and due to venous insufficiency. And we should be able to differentiate telangiectasis from certain liver pathologies such as liver cirrhosis or even the ataxia of telangiectasis. Now we can also talk about palmar erythema, and this is the redness of the palm, especially the thana eminence. As you can see, the place is so red, and we should also differentiate palmar erythema with certain liver diseases due to poor estrogen metabolism, as well as also thyroid toxicosis. And with the positive signs of pregnancy, we say these are diagnostic of pregnancy, that they confirm pregnancy, and it includes the visualization of the gestational sac, either through transvaginal ultrasound by the 4th to the 5th week of gestation, or through the transabdominal ultrasound by the 5th week of gestation, as well as the presence of the yolk sac by the 5th to the 6th week of gestation. Now, anytime we find the gestational sac by the 5th week of gestation, it should correspond to a human chorionic gonadotropic hormone levels of between 1,500 to 2,000 milli-international unit per mil. And these signs are confirmation that the woman is pregnant. And so we don't have any alternative diagnosis of them. Now, by the 5th to the 6th week of gestation, as well as by the 7th week of gestation, we should be able to find the fetal pole, the presence of the fetal heart tones with Doppler at 11 to 12 weeks, and the fetoscope by the 20th week of gestation is also indicative or confirms pregnancy. Then we may also have fetal movement, ability to palpate the fetal parts by the 24th week of gestation may also confirm pregnancy. And we may also visualize fetal movement by late pregnancy. Now, another important thing is that the use of X-ray are no longer used to diagnose pregnancy because of the dangers of irradiation to the fetus. However, this does not prevent us from taking an X-ray if it is clinically indicated. And so in an exams, when you are listing positive signs and ways by which we can diagnose pregnancy, X-ray shouldn't be part of the routine examinations that we are going to do. Now, for descriptive purposes, we are going to look at the positive signs of pregnancy under the pre-pregnant state, the period of decidualization, the appearance of the gestational sac and the yolk sac, and finally the fetal pole. Now, in the pre-pregnant state, we find an antevated and anteflexed uterus with an empty endometrial cavity. And on a transvaginal ultrasound in the mid-sagittal view, we can actually see the fundus of the uterus, the isthmus. Then we can also visualize the cervix, and we can see a collapsed bladder over here anteriorly. So this being the fundus, we have the isthmus, we have our cervix, and we have the bladder which is collapsed over here. Now, the length of the uterus as well as the height can also be measured. Now, by the 2nd and the 3rd week of pregnancy, there is functional and morphological changes as well as the deposition of leukocytes that occur within the endometrium. And this is the period of decidualization. And so this forms the decidual lining into which the blastocyst implants, which is seen as an echogenic thickening of the endometrium. Now, by the 4th and the 5th week of gestation, the gestational sac and the yolk sac appear respectively. What's the difference between the gestational sac and the yolk sac? The gestational sac is the earliest structure which we see after fertilization on an ultrasound. And so when we look at the upper wall of the uterus, we find a small hyperechoic or dark shadow which is surrounded by a hypo or light shadow, as you can find over here. And it is used to confirm a positive intrauterine pregnancy even before the embryo can be viewed. So this is the gestational sac as we can find on an ultrasound. Now, once the embryo develops as a small tissue, there is the formation of the yolk sac. And so the yolk sac is present inside the gestational sac. And so if this is the gestational sac, this round thing here is the yolk sac. And it is attached to the growing embryo on the front, and it can be seen as an echogenic ring, that is the double ring sign, as we can find over here on an ultrasound. And so the yolk sac is the source of nutrition to the embryo in the early stages of pregnancy before the development of the circulation. Now, if the gestational sac reaches 20 millimeters in length, the yolk sac must appear. And when it reaches about 25 millimeters, the fetal pole must appear in the embryo. And so we are able to approximate the events by the development of the gestational sac. Now, the gestational sac should grow 1 millimeter per day after the 5th week of gestation. And so, based on this, it helps us to identify abnormal growth in a pregnancy, or even if the gestational sac is growing normally or not. Now, what about the fetal pole? This is the thickening on the margin of the yolk sac, and we usually see this by the 6th week of gestation through, the transvaginal ultrasound, as you can see. So this is the fetal pole. So this is the gestational sac. This is the yolk sac, and this is the fetal pole. Now, the appearance of the fetal pole may be delayed sometimes until the 9th week of gestation. And when the fetal pole measures about 7 millimeters or more, a fetal heartbeat should be detected. And on an ultrasound, it is seen as an echogenic thickening which is attached to the yolk sac, plus a fetal, cardiac activity, as we can find over here. And so whenever all of these come together, or we find all of these together in a woman, then we have no other, diagnosis other than pregnancy. And so these are what we refer to as the positive, signs of pregnancy. Thank you very much for your attention. Bye-bye.